This is presentation number 5 in the neurovascular imaging series prepared by Prof. Sharaf and revised by Prof. Rami Edward. MRI in stroke by conventional MRI you can be able to see hyperacute, acute, subacute, chronic infarcts, and you can be able also to see if there is hemorrhagic transformation or not, and we will have some examples. Now this is an acute basilar artery occlusion seen as flow void here, and this is the MIP, CT-MIP, CTA-MIP showing the defect. Now here we have contrast enhanced T1 weighted images showing a lot of collaterals on this area of the opercula and the neighboring region due to left middle cerebral artery hyperemia, left middle cerebral artery hyperemia due to hyperacute infarct. There is hyperacute infarct, early hyperacute infarct in this area. There is opening of the vessels showing hyperemia and left hypervascularity. We remember this. I think no. This is another image showing middle cerebral artery occlusion as hyper intense on FLAIR, hypo intense in gradient echo, T2 weighted images, T2 star, and as flow void in the CT-MIP. We remember the core and the penumbra. Core is irreversible damage, penumbra is salvageable, and luxury perfusion is the hyperemia due to compensatory vasodilatation. Now this is a hyperacute infarct shown in T2 weighted images as something subtle. You cannot notice it, and here you find it in the diffusion as core and faint penumbra. In the ADC map the definite core is seen, so this is a point of differentiation between the core and the penumbra by the diffusion and the ADC. By diffusion with the images you are able to see both because of the edema, while in the ADC map you are able to see the core. This is a follow-up diffusion showing the area of irreversible damage or the infarct and the resolution of the edema surrounding. This edema is no longer there. So from this we can say that the difference between diffusion and ADC map is the difference between core and penumbra and core. ADC map is core, while diffusion is both core and penumbra if there is penumbra. In T2 weighted images may be difficult to see any change in hyperacute infarct. This is middle cerebral artery occlusion, and here we have the FLAIR. Here we have the T1 weighted image, the T2 weighted image, the diffusion, the ADC map, and we said that the FLAIR can show both edema and infarct. The T1 weighted image is showed both as low intensity area. In T2 it's not so different from that one, but the difference here between the diffusion and ADC map is not so evident, except for some minimal edema medially here, which disappeared here. That's why the core is very big. The core is very big. Now this one brainstem recent infarct, seen in diffusion as restriction, and seen in T2 weighted images as hyperintensity. This is acute infarct, acute in diffusion, acute in ADC map. The inside part is the core, and the edema is seen as this blackened. So the core is peripheral, and there is a small penumbra around. Again, the difference between this and that is the difference between the edema here and that part of the ADC. The restriction seen here as edema, as hyperintensity, while the edema here is not seen evident. That means that this is penumbra and this is the core. ADC map is core, while the diffusion is both core and penumbra. Core and penumbra, core only, and here is edema, the negative shadow of the edema. T2 weighted images showing hyperintensity, FLAIR showing as diffusion showing as restriction, and ADC map showing as infarct, negative shadow of infarct. This here, there is no much edema because this is the region of the corpus callosum, and the corpus callosum has usually no much edema. So the core is the core with no penumbra seen in ADC map. Again, infarct of the corpus and bifrontal. This is T2 diffusion and ADC map. The T2 is showing subtle changes, hyperintensity here, while the main changes in the corpus callosum here and there are evident. In diffusion with images, extensive infarct bifrontal and the corpus callosum, we expect to see the core in the ADC map, and the core is mainly in this area, and minimal bifrontal changes here and there. So minimal bifrontal and mainly corpus, and minimal anterior corpus, anterior geno of the corpus, but most of the others are penumbra. So most of the edema surrounding the lesions are penumbra, and most of this are penumbra. The difference between diffusion and ADC map, core and penumbra, core only. Acute watershed infarct. This is watershed, means the regions of overlap between two arterial supplies. Here the middle cerebral and posterior cerebral. So infarct starts to appear in this area. This is acute watershed infarct, seen as hyperintensive foci in T2, seen as extensive edema of the right cerebral hemisphere, both anterior and posterior in the diffusion, while in the ADC map it's only this spotty appearance which denotes the core, and the rest of the whole thing are due to edema. Acute small vessel disease, T2 weighted image showing the lesions as periventricular on both sides. FLAIR showing more apparent. Diffusion weighted images shows periventricular hyperintensities of restriction, while in the ADC map only foci of negative or low intensity are seen, denoting small cores with extensive edema of penumbra. This is acute infarct, GIA. Examples of GIAs seen as restriction and diffusion weighted images. FLAIR showing high signal, gvral swelling, and sulcal effacement, denoting cortical edema in a subacute infarct. And here the sulcal edema and the gvral swelling in T1 weighted image. This is FLAIR and T1. In T1 it is not so evident, but still you can see that there is gvral swelling and there is effacement of the sulci, while in FLAIR it is more apparent. Of course, FLAIR gives similar changes to that of diffusion. Subacute infarct, here are the infarcts in FLAIR. Here are the infarcts in T2 weighted images, difficult to see, but in diffusion weighted images it is extensive due to associated vasogenic edema, while in the ADC map it is something localized at the bifrontal region and bioccipital region. Small foci of changes are seen. Now here, after injection of contrast, in a subacute contrast, in subacute infarct, there is enhancing subacute left middle cerebral infarct. Enhancing subacute left middle cerebral infarct. Subacute. In chronic infarct, it will be evident that in FLAIR it follows CSF, in T2 it follows CSF, in diffusions it lost the restriction, and in ADC map it is behaving the same as CSF. So if you want to summarize a hyperacute, it's showing as vasodilatation in contrast examination. Of course it will show restriction. A hyperacute will show extensive edema, but the core will be evident in the ADC map. An acute infarct is usually showing small penumbra and big core. The core is delineated here, sparing only the medial portion, so the penumbra percentage of the penumbra to the core is small to large. in acute midline here, anterior cerebral, there is no penumbra. So expect the penumbra to be big in the subacute, in the hyperacute, and expect that after with time it gets the penumbra gets smaller. Here is an acute small vessel infarct, where almost extensive infarcts are seen in diffusion, and similar distribution ADC maps. There is no much difference, but in FLAIR and T2 there is some edema still. In subacute, now we'll be facing more core, less penumbra. More core and less penumbra. So here bifrontal and right occipital with minimal edema here, seen also in ADC map. In chronic, there is no edema, no penumbra. It's only the infarct, which behaves like CSF. Now what is this? Here we get what we call Wallerian degeneration. The infarct is seen at the region of the right basal ganglia, subsylvian region, territory of the middle cerebral, but it is now extending into the brain stem, and it shows as restriction here in the brain stem. Right cerebral peduncle, restricted diffusion. This is extending from the infarct above. This is called Wallerian degeneration. Here it is. This is the infarct, and these are the T2 high in signal intensity extending into the right cerebral peduncle, called Wallerian degeneration. Again, in infarcts, sometimes we will get lack of oxygen, lack of glucose, or anoxia, hypoglycemia status, epilepticus, ischemic strokes. We get marked cortical effacement and diffuse loss of the blood-brain barrier, and we called, after contrast, we get enhancement of this due to loss of the blood-brain barrier. This is called laminar necrosis. So laminar necrosis is the contrast enhancing cortical tissue. In MRI, it appears as T1 hyper signal, high signal intensity, these lines, in chronic left infarct with mild enlargement of the sulci and associated encephalomalacia in between. So it is due to lack of oxygen or glucose, which result in disturbed blood-brain barrier. So after contrast, it will be apparently like this. It's called laminar necrosis. So amongst the complications of chronic infarcts are Wallerian degeneration and laminar necrosis, and as well as acute hemorrhagic transformation. Hemorrhagic transformation can show. This is not the one. This is acute hemorrhage, in which we have the heterogeneity, and we have the edema, and we have the hemosiderin, and we have the lesions there. So in T2 is similar to diffusion, is similar to ADCs. There is no much penumbra. Penumbra is here, which is not here. This is the penumbra. not much of penumbra still, but we have the big core and big core. This is hemorrhage with heterogeneous intensity. Big core with heterogeneous intensity, including hemosiderin and including edema. Now, this is the complications of infarct. In acute infarct, we might see this petechial hemorrhages seen as low intensity in T2 star, or what we call the gradient T2 weighted images. And here in a chronic infarct, there is hemosiderin with definite bleeding seen as low intensity in the gray in the gradient echo T2 weighted images. So these two T2 star, which are designed to see the hemorrhages, small hemorrhages, either in acute infarct or in hemorrhagic transformation in chronic infarct. How to see non-contrast time of flight? We have 2D and 3D. 2D is for the neck, 3D or for the intracranium. Phase contrast is not used. Contrast enhancement is for the cranium, for the intracranial structures, as well as the neck. So the one used for the intracranial vessels is the 3D time of flight. The one used for the neck is mainly the 2D and the contrast enhanced. This area is now good. So the better is the contrast enhanced MRA. T2 time of flight 2D and contrast enhanced. The best is contrast enhanced. These are the two used in the neck, the 2D time of flight and the contrast enhanced MRA. Contrast enhanced MRA is better than the 2D time of flight. Here we have the normal 3D, decrease the flow related enhancement in the distal. As you are going distally, you will find decreased enhancement. This is 3D time of flight. There is no contrast given. Both. Now this is an example of anterior cerebral artery occlusion in CTA and in 3D time of flight, and this is the infarct as seen in diffusion weighted images as restriction. This right middle cerebral artery occlusion. Now this is maximum intensity projection of 3D time of flight, showing absent flow related enhancement on the right side. Thank you.